A 28-year-old male of no fixed abode presented with a short history of confusion and limb weakness. I am showing you axial, sagittal, and coronal brain MRI scans. Describe the findings.
Let's see. Yes. The brain MRI demonstrates diffuse cerebral atrophy that is highly disproportionate for the patient's young age. In the central pons, there is a large focal area of signal abnormality that is hyperintense on T2-weighted scans and hypointense on T1-weighted scans. Importantly, there is no associated mass effect, midline shift, or surrounding vasogenic edema. The sagittal T1-weighted scan confirms that the lesion is confined to the central pontine tegmentum, sparing the periphery.
I'm showing you a magnified view of the pons. What is the diagnosis and what is the differential?
The diagnosis is central pontine myelinolysis, also referred to as osmotic demyelination syndrome. The differential diagnosis includes an acute basilar artery territory, Pontine infarction, a pontine glioma, and plaque demyelination from multiple sclerosis. An acute basilar stroke would follow a vascular territory and present with acute onset of severe brainstem symptoms. A pontine glioma would demonstrate mass effect, swelling, and infiltration of the pontine fibers.
Explain the pathophysiology and common predisposing factors for this condition.
Central pontine myelinolysis results from the non-inflammatory destruction of myelin sheaths within the pons. This demyelination classically occurs secondary to the rapid correction of chronic hyponatremia. Predisposed patient populations include chronic alcohol abusers, patients with chronic liver disease, severe malnutrition, and Wilson's disease. In this patient, the diffuse cerebral atrophy and history of no fixed abode strongly point to chronic alcohol abuse as the underlying cause.
What are the clinical presentations? And how does the timeline of standard imaging compare to clinical symptoms?
Clinically, patients present with acute confusion, pseudobulbar palsy, spastic tetraplegia, seizures, and progressive coma. Standard MR or CT imaging can be normal for up to 14 days after symptom onset, lagging significantly behind the clinical picture. However, diffusion-weighted imaging is extremely sensitive, showing restricted diffusion in the central pons within 24 hours. Although most commonly confined to the pons, extrapontine myelinolysis can also occur, affecting the basal ganglia, thalamus, and subcortical white matter.
What are the immediate management steps? And how would you manage this patient as a radiologist?
Immediate management is supportive, focusing on neurological rehabilitation, nutritional support, and avoiding rapid serum sodium correction. As a radiologist, I would recommend checking the patient's recent serum sodium levels and reviewing the rate of correction. I would also recommend an MR angiogram of the brain to rule out basilar artery thrombosis or dissection as a cause of pontine signal changes. Finally, I would recommend a follow-up MRI in 2 weeks to define the final extent of demyelination and monitor for recovery.